want to welcome you all to our Zoom meeting, and we would like to thank our sponsors, a company called MEDI-LOFT, and a lady at the helm of the company called Nyasha. She's based in the UK, and she is going to give us a small talk after Dr. Kanonge has finished the presentation. Thank you so much for the support these partners give the society. Without them, most of these meetings would probably not materialize, and would like to thank MEDI-LOFT for coming to the fore and assisting our organization. Our presentation today is a case presentation of 2 patients, Caesarian section scar and rudimentary horn ectopic pregnancies, incidentally diagnosed at laparatomy. And our presenter is Dr. Kanonge, from as far as Chinhoyi. I don't know if it's very, very far from Harare, but Dr. Kanonge is now based in Chinhoyi, and would like to really thank him for preparing this presentation and serving the population of Chinhoyi. A few ground rules, as usual: use your real names. I know everyone is a little lax now because they managed to get all their points, but you still need them for next year. So please make sure you use your real names, no pseudonyms, no phone names when you log into the Zoom meeting. Let's mute our mics. Let's be off video, except for the presenter and the co-host occasionally when they are presenting, to avoid a lot of distraction, especially from the background. If you've got any questions, because this is not an interactive presentation, we leave space at the end for you to give questions. So show by raising your hands, or go to the chat box, which is much easier. It's easier for us to be able to actually follow on the chats as you ask your questions when the presentation is going forward. After that, we will allow MEDI-LOFT a little bit of time to talk about the nature of their business. Up to you, Dr. Kanonge. Welcome.
Thank you very much, Dr. Matereke. Thank you very much for this opportunity. So mine, I'm just going to give 2 case presentations of rare types of ectopic pregnancies. I found these 2 cases interesting, and I thought it would be wise to share with colleagues. So just a bit of a background. An ectopic pregnancy is a pregnancy that implants outside the endometrium. And this is a definition that is widely accepted by many governing bodies. When I was just doing literature review, I was then thought to myself to say, would be a rudimentary horn pregnancy be classified as an ectopic? What about a cesarean section scar pregnancy, since they are both, strictly speaking, in the endometrium? But I then realized that because of the associated morbidity and risk of mortality, these 2 pregnancies actually warrant the same vigilance that we have when we are dealing with the common ectopics, which are the tubal ectopics, which constitute about 95 to 96% of all ectopic pregnancies. Over the past 3 decades, the occurrence of ectopic pregnancies there has been on an upward trend, and it's largely believed that they constitute about 1.2 to 1.4% of all pregnancies, though some researchers and reports suggest that they are up to 2% of all pregnancies. Locally, Dr. Marere did a cross-sectional study. It was an institutional study which gave an incidence of 1.12% with a case fatality of 0.8%. Of note is that there was quite a high occurrence of significant morbidity. Like there was a 77% transfusion rate, and about 38.8% of patients came in with shock, and about 11% required intensive care admission. Of note is that in this series, she did not see any patients who had cesarean scar ectopic pregnancies, as well as any patients with reported Mullerian duct anomalies, which sort of goes to support the rarity of these 2 types of ectopic pregnancies. So today's case is There are 2 cases of cesarean section scar ectopic pregnancy, and then one who had rupture of a rudimentary communicating one in the 2nd trimester. The reason why I chose to present these cases was they are rare. They tend to pose some diagnostic challenges, and as well as the high morbidity that they come with. So moving to the first case, she was a 25-year-old para-3 gravida 4 who was at 12 weeks gestation based on a last normal menstrual period. She was a housewife, and her husband was a 28-year-old farm worker. Her obstetric history: in her first pregnancy, she had a stillborn infant. This was apparently after prolonged labor at a local clinic. In her second pregnancy, she also had prolonged labor, but fortunately, she managed to have a cesarean section offered in time, and the child is alive and well. In a third pregnancy, she attempted vaginal birth after cesarean section, and again had a stillbirth following prolonged labor. So she then came in a fourth pregnancy. She came in acutely with an episode of heavy vaginal bleeding that was associated with severe lower abdominal pain for 1 day. According to this patient, she seemed to notice that the time that she passed a fetus vaginally is the time that she sort of provoked torrential bleeding. And this provoked her to seek help, and roughly arrived at our institution about an hour after the onset of bleeding. The admitting team, on seeing her, rushed her for an urgent pelvic ultrasound scan, which then noted that she had echogenic material in the lower endometrium, which in their assessment thought these were retained products of conception. So the diagnosis at that time was spontaneous incomplete miscarriage. Seeing the heavy bleeding, the admitting team realized that they couldn't wait, so they decided to take it for an emergency evacuation of the uterus. And the only blood investigation that we had was a full blood count, which showed a hemoglobin of 10.7, a leukocytosis of 23.27, and platelet count was normal at 175. So roughly about 20 minutes into starting the curettage, the clinician reported that he saw worsening vaginal bleeding with each attempt of sharp curettage, such that in 20 minutes they lost about 1,500 mils of blood. This is the point when they then decided to call in the obstetricians. Still in theater, in lithotomy position, inspection was performed as well as digital exploration. And it was noted that she actually was bleeding profusely from within the endometrium in area proximal to the cervix. Digital exploration through the cervix also showed a possibility of an anterior uterine wall defect. And at that time, the bladder was catheterized and managed to drain clear urine. So a decision for emergency laparatomy was made. At this point, the estimated blood loss was 2,000 mils, and our suspicion was that this patient actually had an iatrogenic perforation of the uterus. So intraoperatively, we noted that this patient had an anterior uterine defect, anterior uterine wall defect, which was about 5 to 7 centimeters in its transverse diameter. So the tissue around this defect was quite consistent with retained product of conception on just gross inspection. And these RPOCs were gently manually removed. Exploration of the upper endometrium was done, and there was no evidence of any products of conception there. And the defect in the anterior lower segment was quite big, to suggest that there was actually loss of uterine tissue. However, surgical repair was done with some difficulty. So this is a diagram showing a digital exploration of the upper endometrium, showing that there was actually no visible fetal tissue in the upper part of the endometrium. Blood for cross-match and FBC was taken intra-op. And of note is that, just within those few minutes, the hemoglobin had dropped from 10.7 to 2.2. The white cell count with our intra-op FBC was 8.8, and platelet count, it came down to 86. She only managed to get pegged cells 2 hours post-op, because during the time of the surgery, we did not have blood. So post-operatively, we kept the urinary catheter in situ for 7 days, because we worried that due to that deficiency of tissue, we might have injured the bladder. But on discharge, she was now passing urine well with no features of leakage. She received a total of 4 units of pegged cells post-operatively and was discharged on day 7 with stable vital signs and good bladder function. The last hemoglobin concentration before discharge was still low at 7.8 grams per deciliter and was discharged on long-term hematinics. So going on to the discussion regarding this patient, Caesarean section scar pregnancy is a rare form of an ectopic pregnancy, whereby the gestational sac is fully or partially implanted within the scar caused by a previous Caesarean section. The occurrence is reported to be between 1 in 1,800 to 1 in 2,500 of all pregnancies. And it's believed that the incidence is increasing, partly based due to an increasing number of primary Caesarean sections, even the repeat Caesarean sections, as well as the increasing awareness, as the number of case reports is actually increasing in recent times. There's also been improved ultrasound imaging techniques, which has resulted in a higher antenatal diagnosis of such conditions. The diagnostic criteria for Caesarean scar pregnancy is actually an ultrasound-based diagnosis, where the gestational sac is located anteriorly at the level of the internal os within a visible myometrial defect, and functional trophoblastic tissue is demonstrated on color Doppler. This definition I got from an article reported by Dr. Majangara in 2019, after she also encountered a similar case of pregnancy that she published. In their case, this is Dr. Majangara et al. They used both ultrasound scan and magnetic resonance imaging, which both suggested the possibility of Caesarean scar pregnancy. But they had gone to perform hysteroscopy and laparoscopy and could not get a conclusive diagnosis. And this was mostly due to limited visibility posed by adhesions. So this is sort of similar to our case, where she actually presented and had an ultrasound scan, which suggests that products of conception were actually in the lower part of the endometrium. But this sort of did not give us a suspicion. We thought that this was a routine product of conception. Caesarean scar pregnancy can also be classified into type 1 and type 2. And this is based on the direction of growth of the conceptors. So in type 1, the pregnancy is in the anterior myometrium and it grows towards the uterine cavity. Whereas in type 2, the pregnancy is again in the anterior myometrium and it sort of infiltrates the growth, the serosa towards the anterior vesical uterine pouch. Ours was a bit difficult to classify because she passed the fetus vaginally. You would assume that then probably this was a type 1 because the fetus was sort of more in the endometrium. But what of the defect now that we saw anteriorly in the lower segment of the uterus? So we found it very difficult to give it a type to it. So what about the management of Caesarean scar pregnancies? So the general principles in the management is that we want to prevent hemorrhage. We want to preserve fertility because most of these pregnancies occur in women who have future fertility intentions. And then we also want to maintain a good quality of life by limiting morbidity. So the approach to management depends on the gestational age, the hemodynamic stability of the patient, the availability of endoscopic surgeons, and then also future fertility intentions. And then for those who might consider medical management, you should also consider the feasibility of serial serological investigations and imaging with regards to beta ECG and ultrasound scan. So medical management, systemic methotrexate and local embryocides like potassium chloride, hyperosmolar glucose, and even local injection of methotrexate have been used. In some reports, the regression of the mass took anything between 2 months and 12 months to disappear. This was from a report by Siu et al., who predominantly used local injection of methotrexate into the gestational sac. Literature suggests that up to 80% success with medical management and a 6% emergency hysterectomy rate in patients who choose medical management. So this was not an option in our case because she came in as an acutely ill patient with a hemorrhage leading to hypovolemic shock. In addition, this woman was a housewife and they were farm workers. The role for serial beta ECG and ultrasound scan would be actually financially unsustainable to this patient. So there are some predictors for medical management, success for medical management. So an example is if a woman comes with a gestational age less than 8 weeks, or if there's an absent fetal heart activity, and there is a myometrial thickness of less than or equal to 2 millimeters. Surgical management is quite a big, range of surgical management, from dilatation and surgical evacuation, which was attempted initially, but led to a significant hemorrhage, to hysteroscopy, as well as vaginal excision and resuturing. Laparoscopy has also been reported to have a role. In our case, we chose the open laparotomy due to visibility. We were worried about the need for hysterectomy due to profuse hemorrhage, but fortunately, we managed to preserve fertility. In well-resourced centers, there is a role for uterine artery embolization, as well as use of combined embolization and medical management with methotrexate. Follow-up and recurrence, particularly regarding the risk of recurrence, it's always difficult to generalize due to the reality of disease. However, the risk of recurrence is believed to be low. This is based on evidence that suggests that low recurrence in women with high number of any form of hysterectomy. So in other words, we're saying previous evidence has shown that the number of previous uterine surgeries have not been linked with an increased risk of having an ectopic pregnancy in that hysterectomy scar. Shen et al. Had a case series of 42 women, of which 93 of them only had one previous caesarean section. In a systemic review by Reuters, they took all cases published in English between 1966 and 2006. They saw that 52% of the cases had one prior caesarean section, 32% had two prior caesarean section, and 12% had 3 or more prior caesarean section. So there seems to be no trend with regards to the number of previous uterine surgeries. However, this could also be affected by the fact that women who tend to have more number of caesarean sections tend to have a lower chances of future fertility intentions, hence the lower rate of pregnancies in these women. So I would like to move on to the second case that we also managed. So the next case is of a 24-year-old who was para-O, gravida 1. She was at 24 weeks based on her last normal menstrual period. And she came to our hospital as a referral from a district hospital. And their working diagnosis at that time were intrauterine fetal death and septic shock. She had the acute epigastric pain that was associated with vomiting of coffee ground material. Clinically, she had persistent hypotension, tachycardia, that was not responding to intravenous fluid resuscitation. Hence, at their center before referral, they had performed an ultrasound scan, which suggested that she had an intrauterine fetal death. Before referral at the district hospital, they had done a full blood count, which showed a leukocytosis of 35,600 per microliter, and 78% of them were neutrophils. She had a low hemoglobin anemia of 5.9 and platelets were normal at 242,000. After they had reviewed the scan, they had given a start dose of 600 micrograms misoprostol vaginally in an attempt to induce labor, because they had seen that the scan suggested intrauterine fetal death. But because she had not responded, they then referred to us. So on admission, she's a patient who was in hypovolemic shock because the blood pressure was low, 90/30, with tachycardia of 112 beats per minute, and tachypnea with a rate of 28 cycles per minute. She was pale, though fully conscious. A history was significant of vomiting of coffee grounds. This was when we were now talking to the patient. And clinical examination showed that she had an abdominal pelvic mass of 24 weeks gestation, which was consistent with her dates. But this was mildly tender, though she had no guarding. We could not elicit any enlargement of other intra-abdominal organs, but of note, she already had shifting downwards at the time of presentation. We could not auscultate a fetal heart on admission. We then thought of just initiating emergency management, and with the problem list of saying, is she having upper GI bleeding, leading to hypovolemic shock? What is the cause of this intrauterine fetal death? And is it going into sepsis? And we're worried about this free fluid in the peritoneal cavity, to say she had the perforated viscous, possibility of a perforated duodenal ulcer. So we instituted crystalloid intravenous resuscitation. We catheterized and put her on empiric antibiotics. We also did baseline bloods and cross-meshed blood, and gave her emergency management with tranexamic acid, omeprazole, and then for agent abdominal series and an abdominal pelvic scan. We managed to get an ultrasound scan at the time of admission, and it showed that she actually had an extrauterine pregnancy with fetal death. And according to fetal biometry, she had an estimated gestational age of 18 weeks, and there was moderate ascites noted on ultrasound scan. Our repeat full blood count showed that the hemoglobin was coming down from 5.9, it was now 3.3, and she still had leukocytosis, and platelet were still in the low normal range at 147,000. So we managed to get 3 units for her and offered the emergency laparotomy. So at laparotomy, we noted that she had 2,000 mils of hemoperitoneum with a fetus that was in the peritoneal cavity. And this cord and placenta were still attached to a ruptured right rudimentary horn of the uterus. So in this image, we can see the uterus in the dish there with the cord attached to the right horn of the uterus. So the smaller rudimentary horn was attached to the uterus via a relatively small stalk. However, it showed that it actually had a communicating stalk with the larger uterus on the left side. So this image is showing that. Of note is that the fallopian tubes and ovaries were all normal, including those attached to the rudimentary horn. So what we then did at laparotomy is that the rudimentary horn was resected together with its fallopian tube. However, the ipsilateral ovary was retained. So post-op, she's a patient who then made an uncomplicated recovery. She actually was discharged quite early with on day 4 with asymptomatic moderate anemia. Her hemoglobin level had gone up to about 9 after a transfusion of 3 units of blood. So with Mullerian duct anomalies in pregnancy, their occurrence has been very difficult to ascertain. This is because of diagnostic and selection bias. There has also been a lack of objective diagnostic criteria and appropriate classification system of the different anomalies that can affect women in pregnancy. And hence such heterogeneity of studies has contributed to conflict in terms of the occurrence or prevalence of these anomalies among women, particularly if you look at among fertile and infertile women. However, one classification that is very commonly used is the American Society of Reproductive Medicine. It classifies the Mullerian duct anomalies into about 7 classes. And this table demonstrates this. But when I looked at this table, I was like, how do I remember this? But if you notice, it's a general trend to say there is either impaired organogenesis or there is actually impaired fusion of the 2 Mullerian ducts, or the one final option would be impaired septal resorption or canalization of the fused ducts. So our patient, from our findings intra-op, we noted that she actually had a communicating unicornate uterus with a rudimentary communicating horn. That is what she actually had. So for functional purposes, I felt that just to remember that these anomalies can be classified either into impaired organogenesis, impaired fusion, or impaired septal resorption. It makes the counseling of the patient easier, and even the terminology is quite easy to understand from when you explain to the patient. Our patient now, coming back to our patient, this is a patient who has strong desire for future fertility. And we know that the evidence has shown that Mullerian duct anomalies are associated with infertility, recurrent spontaneous miscarriages, intrauterine fetal growth restriction, malposition, preterm labor, as well as retained placenta. We know they are, but now how do we quantify this risk? We needed to discuss this patient to tell you what to look out for in a future fertility. So I then looked at a systemic review of 20 studies that were published between 1953 and 2006. And these are women who particularly had the same condition as our patient, a unicornuate uterus with a communicating rudimentary horn. And they noted that the prevalence or the occurrence of ectopic pregnancy was about 2.7%, which is slightly higher than the background of population risk. You also notice that if you consider the rate of first trimester miscarriages, preterm labor, fetal demise, there are rates that are significantly higher than the baseline population. Therefore, for counseling purposes, like in our patient, we then told her that you've got a 50% chance of achieving a pregnancy that will have a live birth. So meaning that she might be exposed to preterm labor, but at the end of it all, if she keeps trying, she might then manage to achieve a live birth. I also looked to say, how did others, manage their cases when once exposed to such a patient? And Dahia et al., they actually noted that there's a patient who was 26-year-old, para 3 gravida 4 at 12 weeks, who also had an incidental finding of a rudimentary horn ectopic pregnancy. And similar to our case, he also had hemoperitoneuria, and they resulted in the section of both the rudimentary horn as well as the ipsilateral fallopian tube was removed intraop. So my take-home message: cesarean scar pregnancy and rudimentary horn ectopic pregnancy are rare types of early pregnancy emergencies. Imaging is vital in their diagnosis, but this can be inconclusive. They both mimic more common conditions, hence they run the risk of late diagnosis. So at the end of it all, being vigilant with the patient, with our clinical evaluation is important to ensure that we have better patient outcome. Thank you.
Thank you so much, Dr. Kanonge. Wow, very exciting presentations and very exciting cases. I can see a lot of explosive activity in the small town of Chinhoyi there, and we thank you that you are there to assist these women. I will just leave the floor open to questions with regards to the two cases presented by Dr. Kanonge. It's 16:35 now. We can give you about 10 minutes of questions before we pay our dues to MEDI-LOFT. You can show by raising your hands, or you can just maybe unmute and ask your questions, comments, or anything you want to say with regards to the cases. Veronica, you can help me identify those who raise their hands if I'm failing to see any.
So far I don't see anyone. Let me just keep checking.
Hello, okay.
You can go, Dr. Verenga, you can go ahead. There's a lot of echoing and background noise. It's quiet now. I'm sure you can try again.
So thank you so much, Dr. Kanonge. Exciting, the case that we had there. My comment is on the first, probably both cases I want to pass comments. The first one, I'm thinking that probably the first one was a case of a morbidly adherent placenta which miscarried. My question to you is, where do you draw the line between a Caesarean scar pregnancy and a morbidly adherent placenta kind of pregnancy? Because from the case, it appears like this was a morbidly adherent placenta case, which unfortunately miscarried. Then the second one is to do with the investigation mode. I understand you said two pelvic scans were done, which were still very non-conclusive and which were given the impression of a normally sighted pregnancy. But don't you think in this case a transvaginal scan would have shed more information? More so considering the fact that said this woman was induced and the cervix was not changing. We have seen these cases both at Pare and Harare, which have been referred to us because people were inducing them for a number of days, only to do a transvaginal scan and find out that the uterus is actually normal size or just slightly large without any baby in there because the baby is in the abdomen. So yeah, so those are the issues which I wanted to just comment on. Thank you.
Thank you very much, Dr. Verenga. Maybe just to clarify your first question, you are essentially asking if we had a morbidly adherent complete placenta previa, because morbidly adherent placentas sometimes may actually be normally sighted. So I think that's what you are referring to.
I don't know if Dr. Verenga had you, Dr. Matereke.
No, it's fine. You can go ahead and try and respond.
All right. Thank you very much, Dr. Verenga. It's the first question whereby this was whether it was a morbidly adherent placenta or not. It's very difficult to be certain for two reasons. This was an early gestation at 12 weeks. I know the placenta is formed then. And what we could not see the cord because she did not bring the baby. So very difficult to ascertain. But if you go into the definition of a cesarean scar pregnancy, it also fits quite well because she had essentially no myometrium, which what the trophoblast does, it erodes into the myometrium. Hence, I felt like this could have been actually in a cesarean scar ectopic pregnancy more than a morbidly adrenal placenta. We did not see much intra-abdominal hemorrhage, which was also something that worried me. If indeed she was, the pregnancy had gone through the whole myometrium, where I expected much more hemorrhage abdominally. But in this case, there was not much hemorrhage. But it's a very difficult question, and I think it's open for discussion. In terms of your second question, whereby I think the quality of our scans, we have to agree that most of our scans are done by sonographers, and we don't tend to have transvaginal scans. And our index of suspicion is very poor because we are used to seeing so many normal pregnancies, such that we don't stop to think to say, where is this pregnancy? So I agree that a transvaginal scan would have sort of helped us, because I'm sure we would have seen the uterus separate from this gestational sac or this conceptus. It would have sort of given us a suspicion of abnormalities. But like in my literature review, there was that second case where a woman who actually was diagnosed for the first time in a fourth pregnancy. So I think these cases can be missed because we are used to seeing so many normal intrauterine pregnancies, such that one day, once we see a pregnancy, we assume it's intrauterine without actually seeing an anterior myometrium or something like that. I don't know if it answers you, Dr. Werenga.
Well, thank you very much for the response. While Dr. Werenga is working on commenting further to your responses, I've got two raised hands. Dr. Chiwara raised first, and then after Dr. Chiwara with Dr. F. Jim Chan. You can unmute Mr. Chiwara.
Thank you very much. I would like to thank Dr. Kanonge for very interesting cases. My comment, or rather question, is on the second case where you had the rudimentary one pregnancy. This was obviously a patient who was where the fetus had not present even on scan. I didn't hear on the initial clinical assessment what the vaginal examination actual findings were. I don't know whether that was done initially or not, or they were perhaps missed. But why I'm saying that is often when this there is a pregnancy in the rudimentary one or in the abdominal pregnancy, this chronic or advanced pregnancies sometimes might have an impression by doing a careful vaginal examination where you find that in fact the cervix appears fairly firm and closed, unlike in most pregnancies where you can find the cervix soft and it's you can put a finger through. And often you may be able to have an impression that the uterus is pushed to one side. I don't know whether there was actual vaginal assessment or you just missed it in the presentation, Dr. Kanonge. Thank you.
Dr. Kanonge, if you can comment.
All right, thank you very much, sir. The vaginal examination was done. It was, we found it to be normal. The os was closed. Maybe what sort of deceives that in this patient is that she came in with these upper GI symptoms, vomiting, this coffee ground, and thinking, in hindsight, is that most likely this was hemoperitoneum irritating the bowels and inducing vomiting. But we were busy thinking, why is she vomiting? Because the symptoms were mostly in the sort of mid and upper abdominal pain. But indeed, the vaginal examination was done and the os was closed, and she did not have any bleeding at all. But I totally agree that if we had been more careful, I'm sure we would have managed to pick up that there's a mass that's separate from this other mass that's in the abdomen.
Okay, thank you, Dr. Kanonge. While Dr. F. Jim Klanga is preparing to give his comments, there is a question that I also need you to prepare to answer from the chat box, which says, why did you not do a total abdominal hysterectomy in the first case? Because you lost more than 2,500 mils, hemoglobin went down to 2.1, and patient was in shock unless you were sure of diagnosis. Dr. Mhlanga, you can give us your comments.
Yes, thank you, Bismarck, and thank you, Dr. Kanonge, for the presentation. My comment relates to the first case, and it's really to support your presentation and say, I think it also dovetails into what Verenga was commenting on. The diagnosis of a Caesarian ectopic is really made, it's best made very early on. And I don't know about the expertise of making that diagnosis. It becomes tricky to say, is it a morbidly adherent placenta or is it a Caesarian scar ectopic pregnancy? But in reading the comments to these case reports, what comes out consistently is we're not giving it the agency that it deserves once you're able to make the diagnosis that this is a pregnancy developing on the scar, which is typically in the lower segment, and it must be terminated before it causes these complications that Takura described. So I think that we need to be on the lookout for the Caesarean scar ectopic rather than then debating about whether it's a morbidly adherent placenta or not later on. I think Verenga would inform us that if you're able to do these scans in the first trimester early, you would be able to pick out that this is a Caesarean scar ectopic. I don't know how many people will be brave enough to tell their patients that this is the equivalent of a fimbria or ectopic pregnancy and therefore deserves emergency action, even though the patient at that point might not be feeling anything. So that's the comment that I wanted to make. Thank you.
Thank you so much for the comment. And Dr. Kanonge, this one is for you from Dr. Nemachena. He says, very excellent presentations. You need to keep up the good work. I do concur. You are raising the flag for the society very high in the small town of Chinhoyi. I'm just going to allow one more comment because we're already past the time. We also need to pay our dues to our sponsors. Just one more comment or question from
yes, I'm here.
Yes, please go ahead.
It's Prof. Mjaja. Good afternoon.
Afternoon, Prof.
I just want to thank Dr. Kanonge for saving the lives of these two women and of changing what was certainly going to be maternal deaths into near misses. Well done.
Thank
you very much.
Thank you for the comment. So maybe Takura, you can respond to the question why you didn't do a TAH in the first case.
Yes, maybe let me just start by saying thank you, Dr. Mhlanga, for your comments, and also Dr. Nemachena for the comments. And with regards to the question, you know, the issue of hemoglobin coming down to 2, we learned of it, you know, post-operatively, you know, in the heat of the moment, you know, we just did things. As you may be aware, we are 2 here. It's myself and Dr. Mawire. So I was the first on call, and I actually consulted Dr. Mawire to say, boss, can I go ahead and perform a hysterectomy? This patient is bleeding. And then his first question was, what's the parity? How many children? And then he said, let me come, let's see. So actually it was the experienced hand of Dr. Mawire that saved this woman, because at least we managed to control the bleeding. But indeed, I agree that there was also room for hysterectomy. But fortunately, I think we managed to preserve a uterus because we managed to consult someone with more expertise.
Okay, thank you very much, Dr. Kanonge. I think what we can do is you can continue writing your charts. And we can see them after the presentation. And for those who would like to personally discuss with Dr. Kanonge about the presentation, I'm sure you know ways of communicating with him directly. I would say it's time for us to pay our dues. Let me introduce Nyasha Mgara. And Nyasha Mgara is leading an organization called MEDI-LOFT. They are the ones who made this presentation today very possible, and we would like to give them about 10 minutes of our time for them to for them to make a small presentation to members of the society. So please don't leave yet. We'll give the floor to Nyasha. Nyasha, welcome. Are you here? Nyasha, if you can hear me, give me a sign.
Maybe Dr. can stop sharing.
Hello? Nyasha, is that you? Okay, while we are still trying to connect to Nyasha, maybe we can just get maybe one more comment or something like that from the floor while she's setting up. Caroline, if you can try and get in touch with Nyasha. Okay, I think she's here. She's sharing a screen now.
I think Nyasha needs to unmute herself.
No, she's probably muted. Nyasha, can you unmute yourself? Okay, let me see if I can unmute her myself. I hope I would see a name there.
Doc, she says she's trying to unmute herself, but she's failing to.
I've managed to unmute her.
Okay. I'm also sharing a screen. She couldn't share it, so I'm sharing it for her. She's going to be presenting as I share.
Okay, Nyasha, you're unmuted. You can say something. You can put a full screen there, Veronica. I think we're having a few technical glitches with MEDI-LOFT. Let me see if I can call it directly. Nyasha, we can see your screen. You are unmuted. You are not talking. I did unmute you just now. Oh. Yes, I can. Ah, okay. Okay, just try and work something out. If it's not, we can probably give you some time on our next Zoom meeting or something like that. We can always work out something. But just try. We still have about 10 more minutes for our Zoom. So just try and see if you succeed. If you can't, it's not a big problem. Okay. Just try and let me know. Okay, thank you. Well, it seems we're having some challenges, technical challenges. That's always the problems with these Zoom meetings. She's able to chat on the platform, She has just sent a message just now. I've unmuted her, but somehow we are actually failing to hear her talk. So anyone with a burning question, we still have, you know, something like 5-10 minutes left. Anyone with a burning question and burning comment, I would say this is quite very inspiring for us and the new members of the society. It shows that you are not dying by the guillotine if you are seconded to go to a town like Chinoi or Chiredzi or something like that, because the pathology is there and your mentors are also there. And indeed, it's a chance to save lives. And we thank Dr. Kanonge for these inspiring presentations to our members.
Can anyone hear me?
Well, I can clearly hear you, Nyasha. Welcome.
Okay, that's great. Thank you.
Very
I'm so
clear.
sorry about that.
Please introduce yourself and go right ahead with the presentation.
Okay. Hi, everyone. My name is Nyasha Mugara, and I'm a pharmacist. I'm sorry this took a bit of time. I was trying to work out my device, but I won't take too much of your time. Firstly, I'll give you a little bit of a background on who I am. I'm a pharmacist. I studied at De Montfort University, Leicester in the UK. I graduated with an MPharm in 2017. So I've done work in the UK. I'm also registered with Pharmacists Council in Zimbabwe, which is probably one of my proudest achievements. Currently, I work for Fitzpharm. Now, Fitzpharm is located in Ruwa. That's where we're operating from. We've been operating from there for the past 4 years now. And through my work, I've managed to realize that there's so much more that I could be doing in terms of making medication available to a lot of patients in Zimbabwe. So basically, this is what my presentation is about today. We are currently operating from Ruwa. However, I think I want to make this clear so that everyone will get an understanding of where we'll be in the next 4 weeks. So as of 15 November, we will be moving location from Ruwa to GREYSTONE Park. Some of you may be familiar with GREYSTONE Park shops. That's off GAYDON Road, close to the famous pizza place, Pizzazz. There's a gym, and we're very close to Borodale Clinic as well. I will put more about our contact details nearer to when I end my little talk. Now, I'm so grateful for the opportunity I've been granted today. What I would like, what I hope will come out of this is that I would like every doctor in Zimbabwe. And hello? Hello? Am I still on?
Nyasha, you're still on. Yes, we can hear you.
Okay, good. All right, fine. So in the hope that we can make a substantial contribution to the doctor's efforts in improving health outcomes for all patients, we are going to, hello? Oh my God. Hello?
Yes, you are here, Nyasha, loud and clear.
Yes, okay, thank you. I'm so sorry. Okay, let me just jump straight to this, right? Okay, so the purpose of our presentation today is just to alert doctors and to let everyone, oh God, my screen is going off. Oh my God. Hello? Oh my God. Hello?
Yes, please go ahead.
Okay, I'm sorry, Dr. Matereke. I'm really finding it difficult. Just, is my screen, I can't see my screen anymore, but can everyone else see the screens?
We can see your screen clearly, so I'm sure you can just hop on with the presentations.
Okay, that's fine. Okay, I'll just keep talking and then I won't find the screen. That's fine. Okay, fine. So My colleagues and I, we understand that Zimbabwe as a country is going through very difficult times. It's difficult enough to get food requirements, and also medicines can be very, very difficult. So we've been able to develop an efficient and reasonable cost supply chain that enables us to secure medicines and most drugs, and we lend them in Zimbabwe within 14 days at most. Now, this obviously depends on what is required, etc., etc. Now, in terms of OBS and gynae, I understand that this is obviously a bit of a specialist field. You know, most of the medicines that we currently have cover contraceptives, anti-infectives, anti-sickness, HRT, and specialist lines. Now, when we speak of contraceptives, I know most of the time it's almost during my practice in Zimbabwe, I've noticed that people are stuck on just tablets. We also want to be able to offer things like patches, vaginal rings, IUD systems, etc., etc. Our hope is that when the doctor prescribes for a patient, that they're not limited by availability, that they know that whatever they may need for their patient, we can almost certainly get it into the country for you. Specialist lines, obviously, those we can make available as per request. Now we're talking of your anti-cancer treatments, hospital-only medications, and also fertility lines. In terms of HRT, again, different types available, from creams to tablets, to vaginal tablets, patches, etc., all the likes. So we would hope that this offers a new way of prescribing by giving more choice for the patient. Additional services that we also offer as a pharmacy. This includes medicinal use reviews. So this is sort of individual, tailored consultations between patient and pharmacist. And during these consultations, all we do is we review medicines with the patient to speak of side effects, any adherence issues, etc. We also offer minor ailment services. So this is whereby perhaps the patient doesn't need to go to the GP first, but can come to us for that first step help before they go to the doctor. We also do a new medicine service. This is targeted at patients who are starting new medicines, especially the chronic patients, where we work out regimens for them, lifestyle issues, etc., things that are to do with helping them adhere to their medication. Now, we also offer a monthly repeat prescription service. I know from the screen it says deliveries in Harare only, but actually no. We have now partnered up with FedEx, so our delivery has gone nationwide. We deliver anywhere, anywhere, you name it. Mutare, Kwekwe, Gokwe, Lueyo, and with most of the deliveries we do, patients are guaranteed to get medications by the next day, should we get orders by midday, the day before. So we've been putting in a bit of work in terms of logistics and making sure that availability is not limited for any patient. I hope this gives you a bit of a glance of who we are. As I've said, we will be moving to GREYSTONE Park. I will send Veronica details and information of our contact details. Currently, we are operating as Fitzpharmacy in Ruwa, but as of 15 November, we will be MEDI-LOFT Pharmacy and will be located in GREYSTONE Park. We will welcome patients to come to our site, of course. However, we also like to expand on our delivery service, because it's not so much, we certainly don't believe in, you have to be located in a certain area for patients to access you. We would like our base to almost work as just an operational base. Otherwise, medicines should be reachable and available to any patient, no matter where they are. So this is just a bit of information I had for you today. Thank you so much for the time. And I'm so sorry for the technical difficulties. As time moves on, I will be sending Veronica an up-to-date of where we are with our move. And should anyone feel the need to contact me, please do send us an email, contact us on WhatsApp or phone or anything like that. We are available to answer questions. I hope this is useful.
Thank you so very much, Nyasha. And yes, indeed, it's quite very useful. And I'm sure there are a lot of members now quite very excited. Those who are into fertility medicine, menopause, HRT, because these are medications that on the market, most of our clients also tend to find very difficult to access. To all our members, for those who will want probably a one-on-one or to find out more about MEDI-LOFT or Fitzpharmacy, you can get in touch with Veronica. I'm sure she'll be able to hook you up with Fadzi. Would like to thank MEDI-LOFT/Fitzpharmacy for making this day possible by sponsoring our Zoom meetings. I think this brings us to the end of our meeting today. I do not have any announcements except that when it comes to the time for Zoom meetings, I think our first Zoom meeting for 6 p.m. we'll do a trial run in November, the first 2 meetings, and we see how that one goes, and we'll keep on updating. Otherwise, our next, I think that's our next Zoom meeting, Veronica. We don't have another one next week. So
no, we don't. It's in November.
Our next Zoom meeting is going to be November. Take note, it's going to be at 6 p.m. Following the poll that we did earlier. And then we see how that goes, and then we'll review the feasibility of continuing our Zoom meetings at 6 p.m. So with this, we've come to the end of our presentation. Thank you to MEDI-LOFT. Thank you to Dr. Takura Kanonge for an exciting lineup of presentations. And thank you everyone who managed to participate today. Have a great one.
Oh my God, that was horrible, but thank you.